I think the more difficult task is to try to give you where the field is going in only 4 minutes, but I will give it my best. I had no disclosure related with this lecture. Why the mitral valve has been so difficult to approach, and we see this going back to balloon valvuloplasty, and it's because the mitral valve is not like the aortic valve or the pulmonary or even the tricuspid valve. This valve is a true apparatus. It includes leaflets, so it has the anterior and the posterior leaflet, but includes a lot of structures that configure the geometry of the left ventricle, the subvalvular apparatus, the papillary muscles, the left atrium, and all of them contribute to the function of the mitral valve. So one thing that I want you to get, the first conclusion, is very clear that if any one of them could produce mitral regurgitation, there is not going to be such a device that is going to treat all etiologies of mitral regurgitation. And that probably is reflected in the great number of companies that have been looking into treating mitral regurgitation. To make it simple, I think that nowadays mitral regurgitation is divided into two groups. The degenerative group, which is primary MR, and is mainly due to disease of the leaflets. Typical example, mitral valve prolapse. And the second is the functional or secondary MR, and that includes both the old dilated cardiomyopathy with functional MR as well as the ischemic mitral regurgitation. And you could see that there will be more complex as any one of those components that we mentioned will contribute to the development of functional MR. Here is a summary of the activities that are going on the mitral space. The one that have been there the longer is the use of the mitral clip, which is a copy of the bow tie surgery created for Alfieris. You had the E-valve and the Edwards systems. Then there were approaches to the coronary sinus. We very briefly will mention then. There is annular plication, typical of the mitral lint. Devices that could really change the geometry of the left ventricle. Probably the more abroad of them was the MyoCore, which is not available anymore. And there's some interaction between coronary sinus and dimension of the left ventricle, as has been the case with the PS3 or today Maverick device. This is the operation of Alfieri reported in the year 2000. Essentially was the first case of a dual valve on a patient with severe prolapse that couldn't be repaired surgically. Dr. Alfieri decided to make a two-orifice valve, and to surprise, not only he didn't develop mitral stenosis, but more important, mitral regurgitation decreased significantly. And over the course of the year, he performed many of these cases. This is the follow-up, very important follow-up of 465 patients that you could see here that a 5-year follow-up, having only the Alfieri without any annuloplasty associated with it, have a 90% event-free reoperation for mitral disease, telling you that just using the Alfieri alone, you was able to have these very spectacular long-term results. There were ideas of how can we do something like this. There was no doubt there was a big challenge to do this. Thank you to this company, this device became a reality. And the device was the creation of this mitral clip that you could see here is about the size of a dime. And all the system here is a very ingenious generated device that will allow very precise movement of this clip, anterior, posterior, right and left, and they will allow very precise placement of this clip between the anterior and posterior leaflet, creating this double lumen valve. This is, over the course of the year, the selection of patients, and these are the patients that you more likely wanted to choose for the mitral clip. Are patients that have a coaptation length less than 2 millimeters and a coaptation depth more than 11. Patient that will have a flare leaflet, the gap will be more than 10, and the flare width more than 15 millimeters. This device has been submitted to important tests. The first one was the feasibility trial, that was the Everest one, but the more important one was this Everest 2 trial that all of you know very well. I spoke about this before, so I'm really going to very briefly show you that this is the endpoint comparing 2-to-1 the mitral clip against the best surgical cardiac procedure done in the world, which is mitral valve repair. And you could see very clear, looking at the endpoints of the study, which was the safety and the effectiveness, that the patients that were treated with the clip did superior than those patients treated with surgical mitral valve repair. Something that sounds really unreal, but that was the truth. And part of that was that it was a combined event that included a lot of components, many of them obligatory components of cardiac surgery, such as bleeding, transfusions, and so forth. The fact of the matter is that this study endpoint was positive in favor of the mitral clip. More important, when we see what happened to these patients in follow-up, now follow-up up to 3 years of the Everest 2 trial continues to show no significant difference in the mortality of patients treated with the mitral clip versus mitral valve repair. There was one thing that surgery was better and was on the effective reduction of mitral regurgitation. Although there was no translation of this on clinical symptoms, the degree of decrease of mitral regurgitation accomplished was better with surgery than with the clip. This improvement was the same for both groups in terms of remodeling of the left ventricle and in the quality of life system with these patients. These are all the studies that have been done with the mitral clip, and there are more than 1,500 done worldwide, and I think it's going to be very hard to continue to track, as this technique nowadays is widely used in Europe and very widely used in the United States as well today. The other thing that was important to find is that although this device was done to do patients that would have mainly structural heart disease, organic mitral regurgitation, they also found that patients that have functional MR trying with the clip did as well as those patients that did only treated for prolapse. And the similar decrease of mitral regurgitation, similar results. And that brought the co-op trial, where essentially patients that will have functional MR are being randomized. Initially, it was 430 patients enrolled in 75 centers around the United States. It was randomized 1-to-1 mitral clip versus a control group treated with medical therapy for congestive heart failure, with very close clinical and TTE follow-up. This study recently has been upgraded by adding 125 more patients for a total of 155 patients total on the co-op trial, and we're in the process of moving on with the upgrade number to complete the trial. These are the primary endpoints. The primary endpoint is effectivity, 1 year follow-up, recurrent heart failure, and hospitalization for heart failure. And this hypothesis is the superiority for the clip. And primary safety of 1 year is a composed, again, of all these markers that were used in the Everest 2 trial. Very quickly, I will show these 69-year-old patients, including our co-op trial. The patient presents with severe shortness of breath. She has been subject to all kinds of escalating medication, including the use of the biventricular pacing, and continues to have limitation for heart failure, seen by the surgical group decided it was too high risk to do an operation. You could see here a 2D echo showing the severity of mitral regurgitation in this patient. The patient was eventually referred to be one of the enrolling cases on the co-op trial. More than 500 patients in the United States suffer from functional MR, but only a very small number of them are being treated, given the high morbid mortality of this operation on those patients. This study essentially shows you in this one the echo and the fluoroscopy findings. And let me just move to the endpoint of this particular case, which essentially show you the pre and post clipping of this particular patient. This patient is coming out for her 3rd year follow-up, But here is the pre and the 1 year follow-up with practically no change on the severity of mitral regurgitation. I'm going to omit this part of the coronary sinus. It didn't bear out what we really was waiting for. And I want to move to the more important area right now, which is the replacement of the mitral valve. And essentially, there are few companies that have taken to replace the mitral valve, and we have probably the more important of those here, which is Dr. Di Marchena with the Tendyne valve. And I just completely brought the PS3 device. So the valve essentially started with the endovalve, and that was a patent by Dr. Howard Herman, and with some initial work in animals that appears to be interesting. But the major technologies are in the next slide. There are 4 of them. So here you have it. This is the Tendyne valve in the upper left. Here is the use of the Sapien Edwards valve. Here is the cardiac IQ recently acquired by Edwards. The Edward Fortis, and then the deck flow valve that also is being used. Here is the Tiara valve. Here is one example of a patient that has a mitral valve replacement using a Sapien. This is a patient that has severe mitral disease for very calcific mitral annulus calcification. And you could see on this patient, they are entering into the LA, and a small injection showing the big LA and the heavy calcified valve. So the next you see here is the dilatation of the interatrial septum, like at the beginning of the PMBs, we used to do this. And now it was a 12 millimeter balloon. And then you actually use the assembling of the Sapien valve to place it across the all prosthesis in this case, and place it very carefully under TEE and fluoroscopy guidance. You could see the valve very well deployed, and this patient actually got a very nice result. So I will essentially stop there. I don't think that here are the results of some of these valves. Or what I can tell you, I just learned from Dr. Di Marchena that the Tendyne valve is actually over 30 at this time. The largest registry is the Sapien registry with more than 80 patients by Dr. Guerrero in Chicago now. And I specifically omit the paravalvular lead, which will be a very large number of patients as well. They will include this. I think that definitely the future is very bright for the future intervention for the mitral valve. I would recommend stay tuned because this is growing very fast, and I really anticipate a lot of development that will lead to the percutaneous replacement of the mitral valve successfully in the next few years. Thank you.
Thank you, Igor.